Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 559 of our pharmacotherapy series, which majors in schizophrenia. JPJ's psychiatrist decides that in light of her weight gain and worsening glucose and lipid profiles, he is going to change her from olanzapine to lurasidone, titrating her up to 80 mg per day. She did well with the medication change. A few weeks after starting the lurasidone, her parents take JPJ into the emergency room one evening concerned she has meningitis as she feels feverish, is sweating, seems confused, and has a stiff neck. The emergency room exam shows JPJ has a fever of 103.1 degrees Fahrenheit, blood pressure of 176 systolic 98 diastolic, pulse of 136 beats per minute, respiratory rate of 36 breaths per minute, a stiff neck that is not painful, and is sometimes incoherent when answering questions, but shows no outward signs of psychosis. She also is sweating profusely despite the air conditioning in the emergency room. Laboratory work is ordered and returns a couple hours later. JPJ's chemistries are normal except for a creatinine phosphokinase, abbreviated as CPK, of 5,960 micrograms per liter, a normal CBC, and a normal serum glucose. Repeat vital signs 2 hours after she comes to the emergency room show a fever of 103.2 degrees Fahrenheit, blood pressure of 96 systolic 62 diastolic, pulse of 146 beats per minute, and a respiratory rate of 39 breaths per minute. What is the most likely cause of JPJ's presentation at this time and why? How should JPJ be managed? JPJ is most likely suffering from neuroleptic malignant syndrome, abbreviated NMS, from lurasidone. Although neuroleptic malignant syndrome can occur at any time during treatment with any antipsychotic, the timing of this episode shortly after beginning the medication makes it more likely. As she does not have pain in her neck or an elevated WBC, it is not likely meningitis as her parents feared, though this should be definitively ruled out. The high fever, labile blood pressure, tachycardia, sweating, confusion, without psychosis, and highly elevated CPK are indicative of neuroleptic malignant syndrome. JPJ will need to be admitted to the hospital as neuroleptic malignant syndrome can be life-threatening. As she will need to stop taking all antipsychotics for up to 2 weeks, she will most likely require hospitalization during this time as her psychosis is likely to return. During the acute treatment period, she will likely need treatment for the neuroleptic malignant syndrome with either dantrolene, for the fever, or bromocriptine, a dopamine agonist, as well as other measures as needed for her fever, elevated blood pressure, etc. During the longer period without antipsychotic treatment while waiting for the neuroleptic malignant syndrome to resolve, JPJ will likely need treatment with sedatives such as benzodiazepines, as we cannot actively treat her schizophrenia. During the subsequent admission for her episode of neuroleptic malignant syndrome, JPJ is eventually started on aripiprazole for her schizophrenia. A few days into titrating the medication to an effective dose, she develops some mild stiffness in her arms, most likely some mild Parkinsonism. Fearful that this is the neuroleptic malignant syndrome returning, JPJ now refuses to take any antipsychotics. Her psychiatrist decides to start her on a long-acting injectable antipsychotic form of aripiprazole, but notices there are two different versions of the medication available. Which of these two forms would be the better choice for JPJ at this time? Ideally, we would be able to stabilize JPJ on an oral form of aripiprazole prior to conversion to a long-acting injectable antipsychotic form of the medication, but her non-adherence makes that unlikely. Both forms of aripiprazole long-acting injectable antipsychotic require an overlap of oral medication during initiation, 14 days for the monohydrate salt and 21 days for the lauroxyl salt. The main concern is the dosing of the long-acting injectable antipsychotic, however. The monohydrate salt has a single dose for all patients, except in cases of renal impairment of P450 inhibitors or inducers. The lauroxyl salt is dosed based upon a conversion from the dose of oral aripiprazole the patient is currently receiving. As JPJ was never stabilized on an oral dose of aripiprazole before she stopped taking the medication, it would be very difficult to convert her over to an equivalent dose of the lauroxyl long-acting injectable antipsychotic. Therefore, it would be easier to initiate the monohydrate salt version at its usual dose of 400 mg every month, and then try to provide coverage for the initial 14-day window recommended for the product. Regardless of which form is used, JPJ should be monitored for the development of the Parkinsonism she had when being titrated on the oral form of aripiprazole. Over the next few months, JPJ is maintained on aripiprazole monohydrate long-acting injectable antipsychotic 400 mg per month. As her symptoms improved, but she was still showing some signs of daily auditory hallucinations, haloperidol 5 mg per day was added to her regimen. Her hallucinations subsided within a couple weeks after an increase to 10 mg per day of haloperidol, but now JPJ comes in with her parents to the emergency room attached to the clinic. JPJ's neck is turned clockwise to her right shoulder, and she is unable to move her head back to her centerline and look forward. JPJ says her neck hurts a lot and she wants this feeling to go away. What is the most likely reason for JPJ's current complaint and how should it be managed? JPJ is most likely experiencing a dystonic reaction, or dystonia, from the recent addition and increase in her haloperidol dose. The specific type of dystonia she has is called torticollis, which is dystonia causing the muscles of the upper spine to contract and cause a twisting motion of the neck. This is another type of extrapyramidal symptoms, and as seen in JPJ. Here, can often be painful due to the strong muscle contraction. First-generation antipsychotics are more likely to cause this problem than second-generation antipsychotics, so the timing of the reaction to the addition of haloperidol makes sense. Acutely, JPJ's dystonia needs to be treated as quickly as possible as it is painful to her. Oral medications could take an hour or longer to work, so an injectable agent is preferred for more rapid action. As with drug-induced Parkinsonism, the agent of choice is an anticholinergic medication to offset the extrapyramidal symptoms. Most emergency rooms will have either benztropine or diphenhydramine, which has appreciable anticholinergic effects, readily available in an IM or IV form for a case like this. Atropine, while also likely available, is generally not used due to greater systemic and cardiac effects. Benzodiazepines can also be used in IM or IV forms if needed, as they too will help relax the contracted muscles and help JPJ calm down. Additionally, JPJ's medication regimen may need to be adjusted to prevent a future dystonic reaction. A reduction in her haloperidol dose may be needed, or adjunctive oral anticholinergics added to her regimen as prophylaxis. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 560.